A large U.S. health system runs an automated EM tool on every outpatient encounter. The tool levels each chart. The provider confirms. The claim moves forward. Chirok Health then reviewed 40,211 of those encounters. 2 facilities. 1 calendar month. Every encounter already leveled by the automated tool and confirmed by the provider before a Chirok clinical coder looked at the chart. The study was not measuring the tool against no tool. It measured what a human coder adds after the tool has already done its job. That is the variable that matters for the pre-bill decision. Of 18,293 charts, coders left 67.7% unchanged. They corrected 32.3%, raising levels, lowering levels, and reclassifying service types that did not belong in the EM framework. The second facility. 29.8% of 21,918 charts corrected. The pattern held independently, not a single site anomaly. Coders raised levels on 14% of encounters. They lowered levels on 10%. Overcoding is a compliance risk. Undercoding is a revenue gap. Secondary review catches both. Roughly 8% in each sample required a service type correction, not a level adjustment, a reclassification of the service entirely. Preventive visits coded as office visits. Consultations entered as follow-ups. Reviewers were not blinded to the automated level. Anchoring bias suppresses corrections. The 30% rate is the minimum. Under blinded conditions, it would likely be higher. Automated tools process structured inputs. They cannot evaluate clinical consistency, apply payer-specific conventions, or detect when a provider recorded the wrong service type. That is the coder's function. Catching errors before the claim reaches the payer costs a correction. Catching them after costs a claim adjustment, an appeal, or a recoupment. The pre-bill window is where secondary review pays. These findings do not argue against automated EM tools. They argue for layering human review on top of them. The tool does its job. The coder does a different one. 2 facilities. 2 independent samples. Correction rates within 2 points of each other. The data is not ambiguous about what secondary review adds. Chirok Health places certified clinical coders in your pre-bill workflow. The 211 encounter study is what that process looks like in practice.